Hi everyone, welcome to my YouTube channel, TutorMed, where everything medicine is simplified. My name is Kofi, an internal medicine medical officer. This is video number 6 in the TutorMed lecture series, and in today's video, we will be discussing how to interpret the liver tests or liver panel. Kindly support this channel by going through these 4 steps. Like the video, share the link, hit the subscribe button and put on your notification bell. After watching the video, let us know your thoughts in the comment box. Okay, let's get started. Alright folks, before we zoom into the interpretation of the test, let us understand some fundamental principles, beginning with the structure of the liver. Grossly, the liver from the anterior view has 2 lobes, the right and left lobes, and is located in the right hypochondriac region of the abdomen. If any of the lobes were cut through this plane, it will reveal these structures called hepatic lobules. And just like the nephron is said to be the functional unit of the kidney, the hepatic lobule is the functional unit of the liver and contains the hepatocytes, which are the primary liver cells, along with some other cells, like the Kupffer cells, which are macrophages. This is how the cross-section of the lobule looks like. It is predominantly made up of hepatocytes, which are arranged to have a hexagonal shape. These hepatocytes are separated by these blood channels called sinusoids, which drain into the central vein. The central vein of all the lobules join to form the hepatic vein, which subsequently drains into the inferior vena cava. Now these sinusoids receive a dual blood supply from 2 places, 1 the hepatic artery and 2 the portal vein. Again, these hepatocytes are separated by bile channels called bile canaliculi, which drain into the bile duct to be excreted. Now, having understood the structure of the liver, let us pay attention to its functions. As you may know, the liver is said to have over 500 functions, but let us discuss the functions which are relevant to the interpretation of the LFT. As said earlier, the primary cells which carry out the functions of the liver are the hepatocytes. Function number 1. When our GI absorbs amino acids from protein digestion, the portal vein brings it to the liver for protein synthesis, and one of them is albumin. Again, the portal vein supplies these hepatocytes with vitamin K so that vitamin K dependent clotting factors can be produced, and they are clotting factors 2, 7, 9, and 10. Some students use the year 1972 to remember these factors, as in 10 plus 9 is 19, and they add 7 and 2. The third function relevant to the interpretation of the test is bilirubin metabolism. So when red blood cells live 120 days, they are broken down through a series of reactions to form unconjugated bilirubin. The hepatic artery, in addition to bringing oxygenated blood to the liver, brings the bilirubin for conjugation so that they are excreted together with bile salts through the bile duct. Alright, and so summing everything up, the liver has the right and the left lobes, each made of functional units called lobules. These lobules receive dual blood supply from the hepatic artery and the portal veins, and then carry out functions such as albumin and clotting factor synthesis and also bile excretion. The bile exits the intrahepatic biliary system into the extrahepatic system, made up of the extrahepatic and the cystic bile duct, which join to form the common bile duct. The gallbladder stores bile and excretes it into the GI when needed. The point to note here is that the biliary system has an intrahepatic component and the extrahepatic component. Now, how does a typical liver panel look like? The relevant components are divided into the Bay format, B-A-E. Everyone can relate to this mnemonic because almost everyone has a B, isn't it? Alright, so B for bilirubin. It shows the total bilirubin and then a fraction of the unconjugated and the conjugated forms. A for albumin levels. E for the 4 enzymes. 1. Alanine transaminase, abbreviated as ALT. Aspartate transaminase, abbreviated as AST. Alkaline phosphatase, abbreviated as ALP. And then gamma glutamyl transferase, abbreviated as GGT. There are other components such as globulin and then protein, but are not so relevant as the components of the B. INR, which is the patient's prothrombin time over the standard prothrombin time, is a very relevant test of liver function, but is not routinely added to the traditional liver panel, and so it may have to be requested separately. Now, having seen the enzymes we should expect on the liver panel, let us look at them briefly. 1 is alanine aminotransferase, ALT. This enzyme is found predominantly in the liver and so is specific to the liver. The second is the aspartate aminotransferase, AST. This is not specific to the liver as it can be found in other cells like the cardiac and skeletal muscle, the brain, and the RBCs. Next is alkaline phosphatase. Now, the bile channels within the liver is lined by biliary epithelium. And also, there is a part of the hepatocyte membrane that is closer to it. These two membranes, the hepatocyte membrane and then the biliary epithelium, have this membrane-bound enzyme called alkaline phosphatase. It is not only found in these membranes, it can also be found in the placenta and in the bones. The fourth enzyme is the gamma glutamyl transferase, or GGT. It is also found in the hepatocyte membrane closer to the bile channel and also in the biliary epithelium. Not only in the liver, but can be found in seminal vesicles and in the pancreas. Now, when there is necrosis of the cells in the liver, these enzymes are released into circulation to indicate that there is damage, but among them, ALT is specific to the liver. Alright guys, please do not forget to like our video, share the link, hit the subscribe button and put on your notification bell and leave your comments in the comment section. Now let's still pay attention to the parameters in a sample liver panel. For the enzymes, we will see the ALT enzyme value, the AST enzyme value, the ALP enzyme value, and then the GGT enzyme value. Then we move to the total bilirubin value, and for that, we will be given the unconjugated or indirect bilirubin, the conjugated or direct bilirubin. And lastly, we will see the albumin value. These are the relevant parameters. Now the enzymes and then the bilirubin parameters are a test of liver injury or damage. And again, the bilirubin and the albumin are a test of synthetic function. So here you see that in part bilirubin plays or functions or gives an impression of injury, and at the same time it tells us about the synthetic function of the liver. Now, to understanding the key principles of the interpretation, the liver parenchyma should be viewed as two subunits made up of the hepatocellular subunit, which is basically the hepatocytes, which when insulted will give a hepatocellular injury pattern, and then the biliary subunit made up of the bile canaliculi and the biliary epithelium which lines it, together with a part of the hepatocyte membrane which is closer to the bile channels, when insulted, gives a cholestatic injury pattern. We will discuss what cholestasis means in a minute, but first, let's use diagrams to illustrate these subunits. So this diagram shows a part of the hepatic lobule. We have the hepatocytes as shown, which shows the hepatocellular subunit, and then the biliary subunit. When the biliary subunit is viewed or is zoomed, you see that the bile canaliculi are lined by these cholangiocytes, which make up the biliary epithelium. So how do you tell whether the liver injury is hepatocellular or cholestatic? Which enzymes help us to differentiate between the two? ALT, AST elevation indicates hepatocellular injury, while ALP, GGT elevation indicates a cholestatic injury. Cholestasis is simply stasis of bile, and it can be due to the liver's inability to secrete the bile into the bile channel, or the liver has done its work, but there is an obstruction in the bile canal. Remember, we said ALP is a membrane-bound enzyme, and so during cholestasis, the biliary epithelium which lines the bile canal and then the liver's membrane which is closer to the bile canal are forced to release their ALP into circulation, increasing the levels of ALP. And so, ALT-AST derangement supports hepatocellular injury, ALP-GGT derangement supports cholestatic injury. There are many causes of low albumin, including nephrotic syndrome, malabsorption or malnutrition, and liver cirrhosis. And so if low albumin is from hepatic origin, then it suggests that the liver injury is chronic. However, an acute liver injury is indicated by a deranged INR. Alright, so summing everything up, let's look at how to interpret the liver function test. The first step is always check the history and physical exam. And then, on the panel, begin with the liver enzymes. Ask, is there any enzyme derangement? And if there is any derangement, classify the derangement. Is it hepatocellular, cholestatic, or mixed derangement? Then next, look at the bilirubin parameters. Is the total bilirubin elevated? If yes, is it a conjugated or unconjugated hyperbilirubinemia? And lastly, check the albumin level. To see if it is low, then it can indicate a chronic liver insult. Now, in looking at the enzymes, we first ascertain if there is a derangement pattern. How does a hepatocellular injury pattern look like? There will be any derangement in ALT with or without AST, and the derangement level may be mild, moderate, or severe. And for the cholestatic markers, they may be normal or elevated, but if elevated, they will be less than 4 times the upper limit of normal. How about a cholestatic injury pattern? Before we show the pattern, please don't forget that ALP comes from other organs aside the liver, including the bone and the placenta. And so to tell if the ALP rise is hepatic in origin, always check if there is a concurrent rise in the GGT. Also worth mentioning is the fact that GGT also rises in patients who abuse alcohol. And so for the cholestatic pattern, there will be elevated ALP plus a concurrent rise in GGT, and this elevation is more than 4 times the upper limit of normal. while the hepatocellular markers may be normal, or they may be elevated, and if elevated, will be less than 4 times the upper limit of normal. To make this determination more easy and universal, the American College of Gastroenterology has come up with a formula known as R-value. The R-value is equal to the patient's ALT divided by the lab's upper limit of normal, or divided by the patient's ALP divided by the lab's upper limit of normal. If the R value is more than 5, it suggests a hepatocellular injury pattern. If it's between 2 and 5, the picture is a mixed pattern. And if it's less than 2, a cholestatic injury pattern. And so what are the differentials of a hepatocellular injury pattern? Of course, you should be guided by the history and physical exam. But some of the causes are hepatitis A, B, and C infection, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, hereditary hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, drug intoxication. With the aforementioned varied differentials of hepatocellular injury pattern, there are some features which can help narrow the differentials. A useful tool is the De-Ritis ratio. De-Ritis ratio is the ratio of the AST and then ALT. Usually, in most liver diseases, the De-Ritis ratio is less than 1. However, if the De-Ritis ratio is more than 2, it may be suggestive of an alcohol-induced hepatocellular damage. Here is the explanation. Active vitamin B6, known as pyridoxal 5-phosphate, is needed in the synthesis of both ALT and AST, but needed more in the synthesis of ALT. Because of this, if you are deficient in B6, then ALT tends to be secreted less compared to AST. In patients who abuse alcohol, active B6 is deficient, making AST more than ALT, hence making the De-Ritis ratio greater than 2. Alright, now let's see some of the causes of the cholestatic injury pattern. We have primary biliary cholangitis, primary sclerosing cholangitis, obstructive jaundice causes like gallstones, carcinoma of the pancreatic head, periampullary tumor, cholangiosarcoma, and in neonates, biliary atresia. After identifying the injury pattern, examine if there is hyperbilirubinemia. Is it conjugated or unconjugated? For the unconjugated, it could be due to hemolytic anemias like G6PD deficiency, sickle cell disease. Here, the liver panel may be essentially normal, indicating an isolated hyperbilirubinemia, meaning the bilirubin is the only abnormal thing here. But the AST alone may be high because remember that red blood cells also contain AST, and so when we are hemolyzing them, aside producing a lot of bilirubin, you may have AST high. But the ALT, which is specific to the liver, is normal. It could also be caused by inborn errors of metabolism like Gilbert syndrome or Crigler-Najjar syndrome. For conjugated hyperbilirubinemia, it could be due to hepatocellular injuries or disorders like hepatitis, which could be infectious or non-infectious. It could also be any of the cholestatic disorders we listed before. Conjugated hyperbilirubinemia is defined as direct bilirubin which is more than 20% of the total, although some literature say that it should be more than 50% of the total. Then we examine the albumin levels. A normal albumin level in the setting of deranged liver enzymes suggests acute liver injury, because the half-life of albumin is 3 weeks and it takes time to change its concentration. Here, such a patient would have a deranged INR to support that the liver injury is acute. Let's look at some of the causes of hypoalbuminemia. 1. We have liver cirrhosis, and then nephrotic syndrome, protein losing enteropathies, protein energy malnutrition, and then inflammatory states. And so if the history and physical examination agree that the hypoalbuminemia is hepatic in origin, then it means that the liver injury has been a chronic one. Okay guys, on this slide we want to make some general statements. That's 1. In advanced cirrhosis, the liver enzymes may be normal. Also, the ALT or AST may be normal in a patient with chronic inactive hepatitis B infection. That is when the infection is inactive. However, when the patient has exacerbations or flares, the enzymes may be elevated to as high as 10 times the upper limit of normal. Usually, acute injuries give higher enzymes than the chronic ones. And so, acute viral or toxin-mediated hepatitis can give high AST and ALT enzymes, which can be more than 25 times the upper limit of normal. And in ischemic hepatitis, or what is called shock liver, the enzymes may be as high as 50 times the upper limit of normal. Alright guys, how do we report our findings on the liver panel? You should be able to make statements like these. I think my patient has a deranged liver panel showing a chronic hepatocellular injury pattern with direct hyperbilirubinemia, and the diuresis ratio was 1. It was chronic because he had a low albumin, he states the value. I think it's hepatocellular injury because AST, ALT were mostly deranged compared to the cholestatic markers. I think it is direct hyperbilirubinemia because the direct bilirubin represented more than 20% of the total. Another statement is, I think my patient has a normal liver panel, and although the ALP is raised, the GGT is normal, so it may not come from the liver. It could come from the bone, placenta. Very good. Let's take home some summary points. The first is that the name liver function test is a misnomer because, as you can see, the enzymes are not a marker of function but marker of injury. And so instead of saying liver function test, the words liver chemistries, tests, or panels are preferred. Second point is, before interpreting the liver panel, always have a background history and physical exam to guide you in your diagnosis. The third point is, once you pick the panel, first identify if there is enzyme derangement and classify it as hepatocellular, cholestatic, or mixed using the R value. And ensure that the raised enzyme is of hepatic origin. For example, the ALP is of hepatic origin if there is a concomitant increase in GGT. After identifying the injury pattern, see if the function is also deranged by checking the albumin and the INR. The albumin showing a chronic derangement, INR indicating acute injury. Lastly, describe your panel in the background of history and exam, and then generate your diagnosis or differential diagnosis.